Hello everyone, let us study about renal tubular acidosis. Basically what happens is there is some problem in your kidneys causing metabolic acidosis. Okay, and that is normal anion gap metabolic acidosis. There are mainly four types, type 1, 2, 3 and 4. 3 we don't discuss because 3 is basically combination of RTA1 and RTA2. Okay, so RTA1, the problem lies in the distal tubules. There is inability of secretion of proton ions. Okay, so the proton ions are not able to secrete. That's why there is a more protons in your blood and causing metabolic acidosis. RTA2, the problem is in proximal tubule inability of reabsorb the bicarbonate. Normally 80% of bicarb is being reabsorbed in the PCT, but here it doesn't happen, mainly because of symptoms like Fanconi syndrome, that is secondary to heavy metal toxicity, multiple myeloma, or genetic defects in the channels itself. RT4, its problem in the aldosterone deficiency itself or the resistance to aldosterone hormone. That's why what happens is there is impaired potassium secretion, and with that when the protons are not secreted, that's why there is more absorption of potassium and the protons. That's why in RTA4 there will be hyperkalemia. Okay, usually what aldosterone does is it will throw out the potassium and it will reabsorb the sodium, but here because there is a deficiency of aldosterone, more and more potassium is being reabsorbed. Okay, so primary defect, as I said, in that RTA is impaired hydrogen ion secretion in the distal tubules, and in RTA2 it is impaired bicarbonate reabsorption, and RTA4 is impaired aldosterone activity, so there is reduced potassium and hydrogen proton secretion. Okay, so serum potassium, what happens in RTA1? Hypokalemia. RTA2 also hypokalemia. RTA4 it will be hyperkalemia, guys, because there is a more, with protons there is a potassium absorption or there is decreased secretion. Okay, now urine pH, only in RTA1 what happens is it will be alkaline. Why? Because protons are being reabsorbed in the blood, so there is no protons in the urine to make it for the acidification. So only in RTA1 there will be alkaline pH. In other cases it will be acidic pH. Okay, serum bicarb in RTA1 it will be markedly decreased. In RTA2 and 4 it will be mild to moderate reduction in bicarb levels. Urine anion gap, it will be positive in RTA1, negative in RTA2 and positive again in RTA4. Okay, bone involvement, most commonly it happens in RTA1 because of hypercalciuria. Because of that osteomalacia will happen, nephrocalcinosis will happen, nephrolithiasis because of hypercalciuria. In type 2 it might happen but not very rarely. Okay, associations, as I said, RTA1 is associated with the autoimmune disorders like Sjogren's syndrome or SLE. RTA2, either it can be genetic, Fanconi syndrome, heavy metal toxicity, multiple myeloma, etc. RTA4, adrenal insufficiency, either receptor or Addison's disease, like primary there is a aldosterone insufficiency, and diabetic nephropathy, and drugs like ACE inhibitors or NSAIDs, ARBs will cause RTA type 4. Okay, complications in RTA type 1, as it says, because of hypercalciuria, there is nephrocalcinosis, renal stones, chronic kidney disease. Other than that, osteomalacia, rickets, which are common in RTA1, RTA2. RTA4, like hyperkalemia related complications can be there, like arrhythmias related to hyperkalemia. Metabolic acidosis will be there in all three. Treatment is based on basically what we are treating is metabolic acidosis. So we have to remember oral bicarbonate or sodium citrate we have to give in all types. Okay, but potassium related problems you have to treat, right? RTA1 and 2 will have hypokalemia, so you have to think of giving the potassium supplements. Okay, RTA4 will have hyperkalemia, right? So you have to treat the hyperkalemia. How will you treat that? Either you can give by potassium K binders or you can treat by diuretics, etc. So this is the overall discussion of renal tubular acidosis, guys. Thank you.